Okay, so we're going to move into our gastrointestinal chapter, chapter 13. If you also want to look in your ATI book, it's chapter 25, and it starts on page 207. So some of the same things that I'm going to tell you about are also in your ATI book. So again, a good resource is your ATI book to accompany lecture and your pharmacology book. All right, so I'm going to do just a quick review of the digestive system. I know some of you might be bored to tears with this, but it's nice sometimes just to have a refresher. So let's just have a quick anatomy review and move forward. So the GI tract, if you recall from anatomy, is just basically mouth to the esophagus, stomach, intestines, and then all of our accessory structures. So what are your accessory structures? I'm going to tell you, you're going to need to know what those are. So that's going to be your gallbladder, your salivary glands, and your pancreas. Now, the gallbladder has an important part in digestion. The gallbladder stores and secretes enzymes, otherwise known as bile. Okay, so that's the substance that helps us break down things that we take in through the GI tract. Okay, now, can we live without a gallbladder? Yes. Remember, the liver actually makes bile. The gallbladder only stores and secretes it. So sometimes certain people may form gallstones, okay? And that's just a solid piece of matter that forms in the gallbladder, either sometimes from either too much cholesterol or too much bilirubin. It's not definitive as to what actually causes their formation. But anyway, so sometimes they may have to remove the gallbladder because of way too many gallstones. And they may actually end up blocking that bile duct, so then they just remove it. Now there are other times when we are in excruciating pain and we think that our gallbladder is going to kill us, and then we have to have that removed. Okay, it's just not functioning appropriately anymore. So we can survive without it. It's the only real side effect is that there's just not as much bile stored to aid in digestion. Some people who have gallbladders removed tend to have more frequent diarrhea, and that's just because there's less bile to help with digestion, and so the food doesn't stay in there as long. Okay, so that's just a little tidbit, side note there. So the pancreas plays an important part in regulating our fuel for the body. It also helps in digestion, and it regulates our glucose. Okay, so the pancreas produces enzymes. This is your trypsin, amylase, and lipase. Okay, so this is how we start to break down those proteins, fats, and carbs. Okay, those three particular ones help with that. So the pancreas also plays an important part because it secretes insulin and glucagon. Okay, so that's just referring back to fuel for our body. Okay, and last but not least, let's talk about our salivary glands. Okay, so of course they produce saliva, which keeps our mouth hydrated and just kind of helps lubricate that food as we're swallowing it. Now, if you think back to your sympathetic and your parasympathetic pathways, the sympathetic, remember, is our fight or flight. So it reduces that flow of saliva. So, you know, when you're terrified and you're running a marathon, you know, you're breathing heavily, your mouth is dry, you feel like you've eaten cotton or something like that. So this is going to be your anticholinergics. It's that anticholinergic effect. So if you take something like maybe Benadryl or Zyrtec or some type of antihistamine, then you may begin to notice an extremely dry mouth. And so that's why it's got that anticholinergic effect. So there's various different things that can affect our accessory glands. So if you think about all of the things that can affect our accessory glands and the other parts of our digestive tract, then you can imagine how our nutritional status can be affected by those. Okay, so just know what your accessory structures are and just tidbits about what they actually do within the GI tract. Okay, so let's talk a little bit more about the digestive system. So let's talk about what is the purpose of the GI tract and digestion. Well, I'm going to say it's to bring great joy to myself when I'm feeling sad, and I can drown my sorrows in cake and cookies and chocolate ice cream. So it provides nutrients and discards waste. Okay, so it fuels our body. So where does digestion begin? Well, digestion actually begins with the mouth. The minute you put that cookie or that chocolate cake in there or that steak, that's where digestion begins. When you're chewing that up, that mastication, breaking those down, that's where it begins. Okay, now our digestive tract, as we know, starts at the mouth and ends with the anus. Okay, so orifice to orifice. Lots of space in between. So, how do we break down the particles that are ingested? So we're taking in whatever food we so choose, and our digestive tract starts breaking that down into smaller molecules so that we can absorb whatever nutrients we need to fuel our bodies. And then that helps us maintain some type of homeostasis, hopefully. And then it happily packages everything into a solid waste for removal through that lower part of our GI tract, which is the large intestine, rectum, and anus. Okay. So now we know the purpose, and we've talked about where it begins. Let's talk a little bit more about the breakdown. So once we've chewed, whatever it is we so choose, and we've swallowed it, it's going to move through the stomach from the esophagus, and it starts to mix with the stomach acid, which continues breaking down those particles. Okay, so from the stomach, it moves into the small intestine, where it mixes with bile and those pancreatic juices. Now, the pancreatic juices are going to be your lipase, your amylase, your trypsin, and there's a couple of others, but those are the three most widely known. So once it's broken down and it travels through the small intestine, that's where everything is absorbed that our body needs, and then it moves into the large intestine. So then in the large intestine, that's where we begin to absorb some of those that excess water, maybe we need some, or salt, any other nutrient that we can use, our body needs. It is absorbed lastly in that large intestine before excretion. Pack it up, send it out through the rectum and the anus, and we're done with it. Okay, so that's kind of how the breakdown works as far as from mouth to anus. Now, let's talk about the pH of the stomach. We'll talk about it a little bit more in some other slides, but the pH of the stomach is low. Okay, so it's extremely acidic. Now, when you scroll through the next couple of slides, you're going to see a pH scale, and we'll talk about that. But this is where you're going to find the homeostasis for the pH and all that. So when you look at the arrows that are pointing to where the normal stomach acid is. Okay, look at that pH. When you look at it, it's actually on the same scale of battery acid. So if you think about our stomachs and compare it to battery acid, that is probably just about as acidic as it gets. It's like 2 on the pH scale. So think about that. Just remember it has an extremely low pH, and that's how we break that down. Okay, so we're going to talk about some of the protective mechanisms, which we talked about in the previous chapter as we move on through. Okay, so for this particular slide, just know where it begins, pH of the stomach, and what the purpose of the GI tract actually is. Okay, so let's move on to the next one. So this is a slide that I just put in here so that you can just kind of see the breakdown, moving from the mouth all the way through the tract, and it kind of gives you a breakdown of, you know, what each one does. Okay, so the liver breaks down and builds up several molecules. Okay, remember the liver is where we actually, where bile is produced, and the gallbladder stores said bile. Okay, and then it talks about the stomach. This is where it stores and it churns our food. Again, those those digestive enzymes, okay, helps break down that food. Okay, Again, this one talks about the protecting of the stomach wall. Again, going back to the low pH and that acidic environment. So I just kind of wanted you to see this, visualize it, and so if you need to go back to any of these pieces and parts so that you kind of know exactly what they do. Sometimes having a visual, again, as I've always said, kind of helps remember. Here's the pancreas. It talks about the trypsin, the amylase, and the lipase. So the lipase, of course, is going to help digest those lipids, and we talked about proteins and carbs. So just kind of revisit this if you need to, maybe just refresh yourself about what each portion or each part of that GI tract does. Okay. Okay, so let's talk about the transport of nutrients. I put this in here just kind of to give you a visual of how it works from beginning to end. So we're taking food or water in, and again, it's mixed with saliva, those salivary glands, the excretion. It helps, of course, soften and wet that food that we intake to ease swallowing. So it moves through the esophagus into the stomach. Now, this is where partially chewed foods are sometimes called chyme. So you'll see that at the top. That's what that means. I don't know if you remember that from the beginning in Miss Party's class or not, but anyway, just a reminder. So that's just that fluid-like, the semi broken down, partially digested foods in the stomach. Now, I will say that I want you to listen very closely to this. That as partially digested food moves from the stomach and enters the duodenum, which you won't see the duodenum or duodenum, however you want to say it in this particular picture, but the duodenum does not have that protective mucus like the stomach lining does. Okay, remember we talked about those COX-1 inhibitors and the COX-1 previously in the other chapter. Okay, so the duodenum does not have that protective lining like the stomach does. So if you think about your patient, let's just say your patient had an intestinal blockage and we didn't really know about it immediately. Hopefully we would find out very quickly and make them NPO. Okay, but just so we're not causing major harm in that area where that partially digested food is sitting, because if you think about it, that partially digested food has been mixed in all that stomach acid, so it's still very acidic. So now think about how easily it would be to cause ulcerations in that duodenal area. Now, fortunately for the duodenum, the pancreas produces bicarb. Okay, so if you remember back in the last chapter, we talked about bicarb, and the bicarbonate is actually our body's buffer system. Okay, so we talked a little bit about that. So the pancreas actually secretes the bicarb into the duodenum. Now, so that buffers the duodenum, and that acid that's coming from the chyme or that partially digested food that's still acidic. So that's the protective mechanism for the duodenum. Okay, so back to transport. So we've moved into the small intestine, and you'll see in the middle where it talks about digestion that the particles are smaller. So this is where our body starts to absorb all of those particles, the electrolytes, the nutrients, and all of those things. So those are all the things our body are going to use for energy, okay, and to help maintain with homeostasis. I'm sorry, for whatever reason I can't talk this afternoon. Homeostasis, that water and electrolyte balance, okay. So the most important part of absorption happens in the small intestine, okay. So you'll see that while in the small intestine, all of those nutrients and minerals, electrolytes, and water, they're absorbed into the blood and lymph system. Okay, now you'll see the arrows pointing up and they immediately head to the liver. Okay, now this is similar. We talked about the first pass effect with the liver and drugs that you're taking. Now this is pretty much the same. We absorb through blood and lymph. It travels through the hepatic portal vein into the liver for processing and filtering, and then it passes it along to the heart for circulation. Okay, so nothing gets to the heart before it passes through the liver. Okay, so remember that it must pass through that hepatic portal vein before it goes anywhere else to the heart or circulation. Okay, so then once our body has absorbed every single thing that it needs in the small intestine, then you'll see those particles move into the large intestine. It's going to package them and then creating stool, hopefully. Now, I don't think I have to tell you, but maybe I should remind you, of course, that the motion in which all of that moves through the digestive system is, of course, peristalsis. Okay, you probably remember that, but some of you may not recall. So just want to give you that little tidbit of information. Now, while I've told you that 90% of absorption, or the most important part of absorption, happens in the small intestine, I want you to think about someone who might have short gut syndrome. Okay, I know that when I worked in the NICU, we had infants who had perforations, gut perforations, and ultimately necrosis of the bowel. So in certain parts of their GI tract, they had to be removed. Okay, so that's why we call it short gut. So if you go forward thinking about someone who may have some type of stomach issue or a loss of parts of their small intestine, some of the issues that they might have with absorption in nutrients and vitamins and that imbalance in, homeostasis, that water absorption and those types of things. So kind of set your mind to think about those, because going forward, you may have to think about those things. It's important as a nurse to recognize, okay, my patient has short gut, or maybe my patient has some type of liver issue or pancreatic cancer, something. All of that can affect our digestion and absorption. So just kind of keep that in the back of your mind as we move forward, okay? Because all of those pieces and parts are important to complete this cycle from intake to output. So this is the slide I was talking about when I said, as you move forward, look at the pH scale and where you find normal stomach acid. So you'll see the normal stomach acid is way on the left with battery acid, as I said. So we're extremely acidic, okay? So if you think about sodium bicarb, or a lot of people want to refer to it as kind of a baking soda, okay? So you'll see the baking soda move up of more the alkaline area. So bicarb is basically an acid neutralizer. Now, you can also see on the pH scale, we have human saliva. It's right at 7, okay? And blood is right at 7. So if you worked in a hospital or some type of facility and you've really been around respiratory therapists, you may hear them talk about your patient's bicarb level, or they may tell you what it is specifically. Now, when they're doing like an arterial blood gas, they're measuring those, okay? So you may hear them say, oh, your patient is acidotic, or your patient has or is in respiratory acidosis. So that's when you'll hear them, or you'll see an order from a physician say, okay, we need to give bicarb. So they'll give the drug bicarb to bring them back to a normal pH, which is around 735 to 745. That's our homeostasis or homeostatic environment, okay? So just anytime you think about bicarb, just know that that's a buffering system and it is an acid neutralizer, okay? Just kind of wanted you to see that to give you a visual. So what would long-term exposure to this acid in the stomach do to the lining of our entire GI tract? Well, obviously it's going to majorly erode the entire system. Now, a couple of things we've talked about that creates those acidic ulcerations. We didn't talk about reflux. So imagine, and you may have experienced this, you have acid reflux, and you can you can feel that acid coming up because it burns, and you kind of get that nasty, yucky taste in your mouth sometimes, depending on how far it comes up and whether you're laying down or not. That's why we highly suggest that you don't eat and go to bed. So be mindful of that with your patients who may have GI issues such as gastric reflux. Okay, so then how do we protect that? Well, remember back to our previous chapter when we talked about cyclooxygenase and the two types as COX-1 and COX-2 as prostaglandins that normally promote pain, inflammation, and fever. But if you remember, we talked about COX-1 being a good prostaglandin or a good COX. Okay, so it also activates our platelets and our stomach lining. Remember that mucosal lining. So that's how we protect our stomach from long-term exposure to that acid. Okay, now when we also talk about those COX-1 and COX-2 inhibitors that we talked about, those medications that can propitiate some of those issues, remember our non-selective NSAIDs or our COX-1 and COX-2 disruptors. So it affects both of them when we have the non-selective NSAIDs. That's your aspirin, your ibuprofen, and your naproxen. So remember, aspirin again, of course, is going to create a longer bleeding time. So anytime you take any of that on an empty stomach, if we're inhibiting that mucosal lining, we are at risk for ulcers. So just think about those things and remember the good COX is what protects our stomach and the lining with that mucosal excretion. And with aspirin and the ibuprofen and the naproxen, remember if we're inhibiting that COX-1, then we're also interfering with that platelet aggregation. Remember that. That's where the excessive bleeding comes into play. Okay, so remember that as we move on through here. Okay, so antiemetics. With antiemetics, there are several different categories. Um, there are serotonin receptor antagonists, and I want you to listen to this very closely. If you see 5-HT3, you should also know that those are your serotonin receptor antagonists, because not all sources, including tests, are going to say serotonin receptor antagonist. You need to know that they're 5-HT3. Okay, that's another name for them. So if you see that somewhere else, you need to know that. So there's a variety of different antiemetic drugs, and several of them. You can look on page 243 in the little memory jogger near the top of the page on the left side. There are several major categories. So you have the substance P antagonists, you have your phenothiazines or your dopamine antagonists. That's what those are considered. You have cannabinoids. We all know what that is. Your happy little Mary Jane. You have pro-motility drugs. You have butyrophenones, if I say that correctly. And then you have your anticholinergics. So there's several different categories, and we're going to talk about all of them.
Have him on standby.
Okay, so let's talk about serotonin receptor antagonists, and they're typically your citrons. Okay, so back a couple slides ago when we talked about those chemo trigger receptor zones, and I told you once a vomiting center is activated, it notifies the stomach and intestines and ultimately creating vomit. So how does it notify the GI tract? So there's a neurotransmitter that that chemoreceptor center sends back, and that is serotonin. Okay. Now, serotonin is responsible for mostly signals between nerves, so nerve to nerve, and it's mostly found in the digestive tract. And many of you know serotonin plays an important part in our mood. So without serotonin, we can be pretty moody, anxious, and serotonin, of course, plays a huge part in depression. But for GI purposes, serotonin is actually made from tryptophan. And I don't know if you really recall what tryptophan is, but it is an essential amino acid that our body has to have in order to make certain proteins to produce those brain signaling chemicals, such as serotonin. So when you think about tryptophan and a deficiency in tryptophan, you're going to have deficiency in serotonin also. Okay, so think about tryptophan and serotonin in this way. If you think back to maybe Thanksgiving, you've had that big turkey meal, and right shortly after you've eaten, you feel like you're so sleepy, you just simply cannot hold your eyes open. So that's tryptophan. Okay, tryptophan is found largely in turkey. There's a lot of tryptophan there, and so our body absorbs that tryptophan to create those that neurotransmitter serotonin. So that's what causes you to be so sleepy, is that tryptophan. So the tryptophan takes it in, it's absorbed, and then because it's producing, that amino acid has produced so much more serotonin, you can hardly stay awake. Okay, so that's just an example as to how that tryptophan serotonin sleep relates. So we've talked about serotonin in relation to sleep. So it also relates to our mood, as I said, nausea, our sleep and wake cycle, as I said. Now, serotonin is also involved in many other things, and I just want to briefly mention them to you. So blood clotting, bone health, sexual function, and as I said, our overall mental health. Now, why do I tell you all of that? Because when we use a serotonin receptor antagonist, it could affect all of those systems. Okay, so as we move through, just be mindful of the numerous things that serotonin affects. And if we're antagonizing the receptors of serotonin, then the consequences that it can cause. Okay, so let's go ahead and dive into the serotonin receptor antagonist. Or what did I tell you to remember? 5-HT3s, okay? So, this is going to be your Zofran, okay? We talked about ondansetron. That is one of them. This is the drug that's given most often to patients after surgery if they're nauseous. They may even give it to them as a preemptive strike if they know that that patient has a tendency to be nauseous after surgery. But ondansetron or Zofran is one of the most popular ones. It's one of the most commonly used. I'm sure it's probably because of cost. Many of us hospitals, of course, take cost into consideration. So anyway, that 5-HT3, or again, your serotonin receptor antagonist, stops nausea and vomiting by blocking those serotonin receptors. Okay, so if we're blocking it, that serotonin can't trigger the chemoreceptors in that chemoreceptor zone, okay, to induce vomiting. So that's how your antagonist is going to work. So normally if you have a serotonin or you have serotonin and it locks into those receptors, it's going to create that sleep, okay, and it's going to create, whatever else that serotonin does, your mood and things like that. So if we're using an antagonist, remember antagonist blocks that action. So it's blocking the action of serotonin, okay? So now this particular category is typically reserved for cancer patients, any type of patient who's receiving some type of radiation therapy, and then of course your post-surgical patients for that anesthesia-induced nausea and vomiting. I'll get it out in a second, I'm sorry. So if you guys look on page 13 in table, I think it's 13.1, you'll see some of the other antiemetics that are listed. So you have Anzimet or dolasterton, and palanositron. I've never used either of those two. Ondansetron is the one that I have used throughout my entire career. I have never used any of the other two. So just know again that those are going to be your citrons. Okay, so that's what your serotonin receptor antagonists do. Okay, they're blocking the action of serotonin at the receptor sites. And when we talk about these, make sure that you know when we look at these different categories what they're used for specifically or what they're reserved for. Again, this is your chemotherapy, your cancer and radiation patients, okay, along with anesthesia. So I want to explain the cardiac dysrhythmias just a little bit further so that you understand if you were to see this on a test, the reason behind cardiac dysrhythmias being listed as an adverse reaction. So serotonin has, remember, that vasoconstrictive action. So when we vasoconstrict, our heart rate's going to increase and it increases the force of contractions. Okay, so this is where you're going to see that arrhythmia, the change from maybe a normal rhythm into a dysrhythmia or arrhythmia, whatever you want to call it. So you have to think about also your patients who have hypertension. Is this a good drug for them? Is this is there something else out there that maybe doesn't cause that constriction and therefore affecting those cardiac valves and the work of the heart, and then of course those dysrhythmias. So as you're thinking about your 5-HT3s, think about those patients who have some type of cardiovascular disease and whether this is truly a good choice for them or not. Can we give them something else? Okay, this is why most of the time you don't see Zofran used in long-term or for as a long-term fix. Okay, this is why you don't really see this used a lot in pregnancy. Okay, because it does have those severe adverse reactions. So just kind of think about those and keep that in the back of your mind. That's where those cardiac dysrhythmias come into play, is because of that vasoconstrictive properties of serotonin. So our nursing responsibilities and teaching for patients who are taking our serotonin receptor agonists or the 5-HT3s, like the ondansetron. Um, First of all, it's going to start with monitoring our vital signs. Remember, we always want to get a baseline so that we can see what those changes are or what changes follow once we give that medication, especially Being mindful of timeliness when we have patients who are on chemo and we're giving this particular type of medication to prevent that nausea, hopefully preventing nausea. Remember, that's a noxic thing that's being entered into their body. So we want to always make sure we're trying to head that off at the pass. Okay. So being mindful of administering to those chemo patients in a timely manner. Um, let's see. Now, I've already told you that some of the serious side effects of serotonin syndrome that can go along with the 5-HT3s and the cardiac dysrhythmias that it can cause, we want to make sure that if we have a baseline EKG strip, that we're monitoring that. Review it, okay? If it's not in your chart, look on your system, okay? Most of the time, you'll be able to find one somewhere if they've had one before. Drug reconciliations, I've told you how important those are. Again, St. John's wort, okay, that's an herbal. It's taken to increase mood. And so we certainly want to look for those antidepressants, those anti-anxiety medications. Those are your MAOIs and your SSRIs, those types of things, and then some over-the-counters also. So make sure that you're educating them and looking yourself at those medications that they're taking for those types of interactions. Remind your patients to be cautious in driving or operating heavy machinery. You're going to hear about driving and operating heavy machinery through this entire series in pharmacology, because if you have a sedated patient, we don't particularly like them behind the wheel, okay, and endangers themselves and others. Now that we know, and I know you guys, I sent an email out, you know what CNS depression is, we understand that alcohol does the same thing in the CNS pathway. Okay, it has that sedation effect, so we want to make sure that we're not giving those serotonin receptor agonists causing CNS depression as a side effect, and then them drinking alcohol, which also decreases that CNS effect. Okay, so it's kind of like double dosing, as I typically say. So be mindful of educating them about not taking this particular class of medication with alcohol because of those extreme sedation effects, okay? Because, again, if you're taking the medication and you're drinking alcohol, as I say, you're getting double the dose and you're getting double the side effects, okay? So be mindful of those responsibilities as a nurse. Now, substance P neurokinin receptor antagonists are typically your pittance. The most widely used is aprepitant. So, substance P and the neurokinin receptor is just another receptor area in our body that can cause nausea and vomiting. Okay, substance P is produced by various cells in the body. And so once we are exposed to some type of trauma or inflammation and pain, or even some type of noxious stimuli, then substance P is produced. So substance P travels through the bloodstream, up through the CNS to the brain, and bonds at the neurokinin 1 receptor. Okay, so the neurokinin 1 receptor is the best receptor site for adherence for substance P. So they're in the chemoreceptor trigger zone. And also in that chemoreceptor trigger zone, remember there are some pain receptors that are triggered there also. So substance P can be found in the peripheral nervous system as well as the central nervous system. Okay, so it's pretty much found everywhere. Now, substance P stimulates either immediate nausea and vomiting, or it can cause delayed nausea and vomiting. Okay, so once it binds to that neurokinin receptor, it can cause either or. Now, this particular class of medication is reserved typically for cancer treatment, the chemotherapy use, and after surgery, because we can block that neurokinin receptor in that chemoreceptor trigger zone so that we reduce those feelings of pain and nausea and vomiting. So they're very useful after surgery and especially useful in cancer treatment. Now, when we talk about cancer treatment, it's particularly effective because we can antagonize that receptor site to prevent that delayed vomiting that your patients experience. Typically, with cancer patients, they're having their treatments in an outpatient facility, so they may not have immediate nausea and vomiting, although they can. And a lot of times when they're in the facility, they will treat them with your ondansetron, okay, those 5-HT3s. So those are found more effective in treating the acute nausea and vomiting, whereas this is particularly effective in treating that delayed vomiting because your cancer patients come in, they have their infusion, they go home. So 24 hours, or I think even up to 72 hours is what your book says, they can experience that delayed nausea and vomiting feeling. Okay, so this is especially important for your cancer patients. Now, long time ago, they used to use corticosteroids in treating that delayed vomiting and nausea. I'm not really sure how that worked exactly and what the science behind that was, but it can still be used in conjunction with corticosteroid treatment. So you may see your patient taking those 5-HT3s and your substance P neurokinin receptor antagonists. So you can have dual treatment, okay, because we want to treat the acute nausea and vomiting, and then we also want to make sure that we're treating that delayed nausea and vomiting that they may have once they go home after treatment. So when you're filling out your sheets for your medications for this particular chapter and you do your therapeutic uses, you should be especially mindful of the fact that this is for surgery patients, chemo patients, and treating that delayed vomiting. Okay, that's your cue, delayed vomiting in this particular class of drugs. Okay, guys, let's move on to the expected side effects and the adverse effects. Okay, so I want to tell you initially how a prepotent causes some of these adverse effects. If you understand about a prepotent and its components, then you're better able to understand the adverse effects and why it causes them. So a prepotent and its chemical structure is actually considered a moderate cytochrome inhibitor. So you're going to ask me, what is that moderate cytochrome inhibitor? So I had to refresh myself because I went to nursing school 11, 12 years ago. So a cytochrome is basically just a substance that binds to a heme protein, okay? And we all know that heme binds to iron, and iron and that heme is basically essentially together the oxygen carrying piece we all know as hemoglobin. Okay, so does that make sense? All right, so just I wanted to relate to you that it was a cytochrome that relates to heme that binds to iron, creating that oxygen carrying ability. So that way, once we get to the adverse effects, you'll understand them a little bit better. Okay, so some of the complications with the use of a prepotent is, of course, fatigue, diarrhea, headaches, dizziness, mild hiccups, flatulence, and sweating. All right, so if you recall what serotonin does in the GI tract, it regulates that bowel function because it plays an important part in smooth muscle function in the GI tract. So that's where you're going to get that flatulence and some of that diarrhea. And remember, we also talked about serotonin and some of the other things that it can affect our mood. It can impact our sleep. So we talked about that just a couple of slides ago. So this is where those particular side effects come from. That's where they stem from. Now, as far as hiccups, the research I've done is inconclusive as to why this particular medication causes hiccups. Okay, I don't know. Dizziness comes from the serotonin being a vasoconstrictor. Okay, so that's where you're going to see the dizziness. Now, sweating, if I don't know if I mentioned this or not, but serotonin plays a part in your central nervous system as well as the GI tract. So um, that may lead to triggering something in your central nervous system that controls our core temperature regulator. Okay, so that's where you get the sweating from. So those are your expected side effects. So um, fatigue, let me just tell you, fatigue, and remember I just told you that this particular medication is related to cytochrome slash heme related to oxygen. So that's where your fatigue comes in. Okay, if they don't have enough hemoglobin in there and they're not transporting that oxygen, they're going to be fatigued. Okay, and we'll talk a little bit more about that when we move into the adverse effects. Okay, so adverse effects. So the adverse effects are neutropenia, angioedema, anemia, thrombocytopenia, and so let's talk about those. So the adverse effects of this drug, of course, can cause neutropenia. And you guys know by now that I'm a huge proponent in knowing what neutropenia means. You can say neutropenia all day long, but if you don't know what it means and how to apply that to your patient, it doesn't do any of us any good. Okay, so neutropenia, you may or may not recall, is just a lack of neutrophils, which basically translates into a low white blood cell count. Okay, so I don't know if you remember that from fundamentals or whatever they call it in the first trimester, but that's what it is. So if I said to you, if I'm the physician and I said to you as a nurse, I need you to check some labs for me, a CBC for this patient, and it comes back with a low level of white blood cells. Well, based on those lab results, they may require you to put your patient into what we call neutropenic precautions. Now, neutropenic precautions, for those of you who don't work in a hospital setting already, is basically we're protecting the patient rather than us protecting ourselves from something that the patient may have. Okay, they have a low white blood cell count, they can't fight off infections as easily, so we're protecting them. Okay, so some of the neutropenic precautions are they can't have certain foods. I don't know exactly what they are. I can't recall, but live flowers, anything like that, they can't have in the room because of that increased risk for infection. Okay, so that's what neutropenia means. If you don't understand it or you need further discussion on that, we'll talk about it. Thrombocytopenia. Again, you may or may not recall what some thrombocytopenia is. Okay, that's just simply your low blood platelet count. We don't have enough platelets to form a clot, therefore we're going to have that increased bleeding time. Now, when I say thrombocytopenia, when we talk about labs again, okay, it's important for you guys to understand the certain labs that you're going to be looking at and reviewing to lead you to, oh, this patient has thrombocytopenia or this patient is anemic. Okay, so thrombocytopenia with that prolonged bleeding is going to lead you back to the PT, which is your prothrombin, your PTT, and your INR. Okay, that's just your prolonged bleeding times. So those are the labs that you should assess, and if they're low, lead you back to thrombocytopenia. Okay, anemia, just that lack of healthy red blood cells that carry oxygen to our body tissue. Okay, if we're not getting that oxygen, we're not feeling very sprite, I guess I should say. Okay, if you know anyone who is anemic, then you probably have recognized that they're usually pale in color, excuse me, and they seem fatigued all the time. Okay, they're just lacking that that extra oxygen, or those red blood cells that carry oxygen to the body tissues. So that's where the fatigue comes in. Now, angioedema, I don't know if we've talked about that in this course yet or not, but anyway, angioedema, if you've ever seen someone who has had an allergic reaction, it's kind of what that picture looks like, okay? You're going to see them with maybe a little bit of the swollen lips, a little bit of swelling around the eyes and the forehead. Sometimes you'll be able to see this on the neck, okay? It's basically just swelling underneath, right underneath the epidermis, okay, or the dermis. So if you've never really seen an allergic reaction, just look up one of the slides on Google or something, and you can visualize what that looks like. And so again, respiratory depression is the last one. And again, that goes back to all of the things we talked about previously. Okay, the inability to carry those red blood cells and oxygen. Okay, so if you guys have any questions about the pathophysiology of all of this and why it causes certain side effects and adverse effects, please let's talk about it. Write down your questions as we talk about this, and then hopefully we'll implement a Zoom meeting and we'll talk about them. Okay, if there's anything at all that I have said in this lecture in this particular slide that you don't understand, please write it down. Send me an email. I'll keep it on my list for our meeting. Just don't not do anything. Okay, if you don't understand it, please let me know. As far as drug interactions, there's just a few listed. That's going to be your opioids and your benzodiazepines. Again, those two particular medications cause dizziness, drowsiness, and of course, sedation. That's what the actions or the effects of their actions do to your patient who's taking them. So if you recall a couple slides back, I talked about serotonin syndrome. Okay, so when we take a certain medication that is inhibiting that use of serotonin or the adherence to those receptor sites, and we have that excess of serotonin circulating in our bodies. So remember, serotonin does affect our sleep cycle. So if we have all that excess serotonin in there, we're going to be drowsy, we're going to be sleepy, and then if we have an additional medication that we're taking, those opioids and those benzos, then that is going to make it even worse. Again, that goes back to that double dosing that I talk about. So this goes back to, of course, doing really good drug reconciliations when you're giving your patients certain medications, especially if they're just starting that medication. Okay, so just be mindful of those two drug interactions. This particular medication, if you look in your book on page 246, has specific mixing instructions. So anytime you have specific mixing instructions or storage, make sure that you're educating your patient on those. Some medications are light sensitive, and you will notice that sometimes if you work in a facility, they'll come up in an amber bag. That's to protect them from light. So if you see something as far as mixing preparations and things like that, be mindful of those. So really the importance of these instructions is to remind your patient to either, if you're administering it or they're doing it, mix them appropriately and gently swirling the solution. This one says 20 times specifically, but just don't shake those medications, okay? Foaming can occur, lots of bubbles. And then if you have lots of little clumps in there and you didn't take the time to let it dissolve appropriately, and you pull your dosage before it completely dissolves appropriately, then is your patient getting the correct dose? Probably not. It also talks about the injectable. Some of those come in like the pre-filled syringes, and you can invert them, you know, back and forth, back and forth. And you can gently roll them between your hands. Do not just shake them. Again, you create that bubbles, foaming, and then it can affect your dosing, especially if it's a powder form that you have to reconstitute. Okay, so we want to make sure we're giving them the right dosage. So in doing so, we have to make sure that we are preparing it correctly. We talked about storage, and so as far as over-the-counters and alcohol, again, this particular medication, it says refrigerate up to 30 days. So make sure that you're educating your patient anytime you have any type of certain preparation, mixing, or storage instructions, teaching them about those. Over the counters, I've mentioned this many times. St. John's wort is an over the counter or herbal, I guess I should say, that many people take because it is known as a mood booster. So we know that if it's a mood booster, it's probably affecting our serotonin levels. Again, so that should lead you back to that serotonin syndrome. If we're already inhibiting those serotonin receptors, we have that excess of serotonin floating around in there. So we don't want to take St. John's wort that also is shown to increase serotonin and mood. Okay, so that's why we want to make sure we're doing that drug reconciliation and asking about those herbals and over the counters. Alcohol, of course, has those sedative or sedating effects. It's CNS depressing, and so we want to make sure that we ask them to avoid alcohol or just educate them about it, because our medication that we're taking, our substance P neurokinins, also can cause the same CNS depression, that dizziness, drowsiness, and sedation. Okay, so again, that kind of double dosing, as I call it. Okay, we don't want to drink alcohol and take this medication because we're further depressing that CNS activity. So phenothiazines, or your azines, remember those prefix and suffixes and the importance of remembering those. Those will greatly help you as you move along in your career to recognize certain categories. Okay, so this particular class is an antiemetic, but they're also a dopamine antagonist. Remember, an antagonist, again, blocks an action at the receptor site. Okay, so these two will block the dopamine receptors in that chemotrigger receptor zone. Okay, so dopamine, just FYI, is typically considered one of our feel-good neurotransmitters and hormones. Okay, just like serotonin, we talked about how many different parts of our body that can affect. Dopamine is the same way. Okay, so in order to understand this particular category, you need to know about dopamine. So let's talk just a little bit about it being a neurotransmitter. So if you have ever experienced patient care with someone who has a diagnosis of Parkinson's, then you've probably heard a little bit about dopamine or some of the drugs that they're taking. It does affect different parts of our body, and in Parkinson's, what happens is the dopamine as a neurotransmitter is not as available as what it was previously. So therefore you'll see I have these EPS at the bottom of the slide. So most of the time, the way they diagnose Parkinson's is by signs and symptoms. There's no clear test for Parkinson's disease. Now, this particular group of medications is not a medication group that you can use during pregnancy. Okay, there have been some studies shown to have an increase in miscarriage for mothers, but as far as this category, just make a special note that we do not use these for morning sickness during pregnancy. Okay, so some of the expected side effects for this particular category, your phenothiazines, is your blurred vision, dry mouth, dizziness. Now, some phenothiazines can cause a change in urine color, so be mindful of teaching your patient that so they're not alarmed if they're like, oh my gosh, my urine is pink. That's okay, it's expected. Okay. This medication can also cause some sun sensitivities or light sensitivities, so be sure that you, again, educate your patient about the fact that they need to, one, wear sunblock if they're out in the sun, or two, limiting that sun exposure as much as possible while they're taking this particular medication. Now, the adverse effects of phenothiazine are going to be those extrapyramidal symptoms. Okay, so those extrapyramidal symptoms is what we see in our patients who have Parkinson's. So this is going to be your tardive dyskinesia, acute dystonia, and even neuroleptic malignant syndrome. Okay, this group can also cause some blood abnormalities. So patients with cardiovascular disease should not take these particular medications, or we want to avoid them as much as possible in giving them. So it's important to understand what extrapyramidal symptoms look like. If you, again, have ever been around someone with Parkinson's, then you may recognize a couple of them as we talk about them. So tardive dyskinesia is just an involuntary repetitive movement. You may have seen them rolling their tongue or smacking their lips, just that continuous repetitive movement, okay? It's not something they can control. Now, akathisia is one that you'll sometimes see, and it's just a complete muscle spasm. You may have someone who has a diagnosis of Parkinson's and they're sitting at a dinner table and all of a sudden you see their legs suddenly move or their arms fly up in the air or something of that nature. So again, that is just your akathisia, just that discoordinated movements. Let's see what else. EPS. One of the other ones is feet shuffling. If you've ever noticed how sometimes a patient with Parkinson's have a shuffling gait, or if you hear us talk about a shuffling gait, they are walking by really not moving their feet away from the ground. Okay, they're sort of just shuffling along. And usually they have their head down, and it's almost like a robotic movement, okay? And sometimes they may even stop, freeze in place, okay? And this is just because that dopamine is not available to those neuroreceptors, and so they're not transmitting the appropriate signals. So that's where you get your extrapyramidal symptoms. Now, neuroleptic malignant syndrome can be life-threatening if it's left untreated. Okay, now this one includes an extremely high fever. And when I say that, I am referring to fevers of greater than 102 to even 105. Okay, you're going to see extreme muscle stiffness, almost that muscle rigidity. Okay, sweating, of course, and then increased heart rate and confusion. So those are just some of the things that you're going to see in those patients. Now, when we talk about the MAOIs, the antidepressants, it's important to understand that what happens is we take MAOIs and we take antidepressants so that we can actually increase the availability of that serotonin and dopamine so that, number one, we can help with depression. Okay, again, that's our feel-good hormone and neurotransmitter. So if we're blocking the action of that dopamine that that person is taking, then we're not improving their mood or depression or anything else. Okay, so make sure that you kind of understand how to relate those to those MAOIs and those antidepressants. Now, the levodopa-carbidopa is a combination drug that they use in patients who have Parkinson's disease to alleviate some of those extrapyramidal symptoms. So we don't want to give them something to help treat Parkinson's and then block the action of the medication we're giving for Parkinson's. So that's why there's that drug-to-drug interaction with those phenothiazines. Now, with your benzodiazepines, of course, we all know that those cause some sedation. And so, again, we don't want to create that effect with further sedating that patient by giving them phenothiazines along with a benzodiazepine. Okay. So one last important factor to understand about phenothiazines and why you have that drug-to-drug interaction, especially with the levodopa, carbidopa, and anything that might interfere with that dopamine in addition to the phenothiazines, is because if we give them phenothiazines and they're taking this levodopa, carbidopa, and they're experiencing those adverse effects from those phenothiazines, how do we know if it is truly a Parkinson's syndrome symptom appearing, or is it that your patient is actually experiencing those adverse effects from that Phenergan and that Compazine? So that is extremely important for you guys to know why that levodopa, carbidopa, and those MAOIs and antidepressants would have that masked, or that they would be able to mask the symptoms of an adverse reaction to phenothiazines. Okay, now if you have any other questions about how those interact, please email me and we'll discuss that. So cannabinoids, this is going to be your dronabinol and your marinol. Okay, THC is actually the psychoactive component of marijuana. Okay, so every single one of us have THC receptors in different parts of our brain. Okay, now they're specifically found in the pleasure centers of the brain. Okay, so that's why many times this is addictive. Okay, so with cannabinoids, has two actions. One, it binds to the THC receptors in the pleasure brain of the area of the brain, or by inhibiting serotonin from binding to its receptor in that same chemoreceptor zone, preventing nausea and vomiting. Okay, so cannabinoids can have two actions, okay, but they both work in the brain. Now, cannabinoids are typically used for severe nausea. Okay, so if you're testing and you see A, B, C, or D and your selection is severe nausea, you need to think back to cannabinoids. Okay, again, it's proved in some states, and we typically only give this in instances where everything else has been tried and failed. Okay, now, with these prescriptions, a lot of times it's going to be your cancer patients. Sometimes they have used these, one of the two, in patients who have gastroparesis. Now, gastroparesis is a disorder in the stomach with the smooth muscles in which they basically just become paralyzed on and off, causing that severe nausea and vomiting, because with that gastroparesis, all of those stomach contents are just sitting there. They're not moving through the GI tract like they should. Okay, so they give that THC to help with that nausea and vomiting. And of course, with your cancer and chemo patients, it's useful. Now, of course, we want to talk about the expected side effects, and that is our high that we get from the use of marijuana or the THC. So we have to consider addiction or history of addiction when prescribing this particular group. So some of the other effects, of course, are going to be in your central nervous system. That's going to, remember, THC works in our pleasure center. So you're going to see some dizziness, anxiety, maybe some insomnia, difficulty concentrating, and mood changes. Now, I don't know about you, but when I've been around people who are, maybe under the influence of marijuana, they all seem pretty happy to me, but just know that those are some of the side effects that can occur. Okay, so anxiety and insomnia and difficulty concentrating, along with those mood changes, simply just go back to the fact that cannabinoids block those serotonin receptors. Now remember, serotonin influences many things in our body, some of which is our sleep and our mood. So that's how that relates to those effects. Now, some patients have GI side effects, the nausea, the vomiting, the abdominal pain. Now that too relates back to serotonin, because remember, serotonin is present in the stomach, and without it, we can suffer from a lot of gastrointestinal issues. Now, one in particular is orthostatic hypotension. Okay, that is an expected side effect. So remember, especially with your older patients, we have to be mindful of falls with them and educating them about that. Okay, so anytime you have hypertension or dizziness or sedation, we should immediately be mindful of the increased risk for falls. So now the adverse reactions, this is your acute confusion, some hypersensitivities, seizure-like activities, and even hallucinations in some patients, sweating or fainting. Again, remember the receptors are found in many areas of the brain. So this is why you see some of those central nervous system side effects, okay? Now, with the drug-to-drug interactions, that includes your warfarin, your calcium channel blockers, your opioid agonists, and some of those anti-retrovirals, which is typically for the treatment of HIV. So, of course, again, we know that if we take an opioid, then we're going to probably see some type of sedation with our patients. And so with THC, it can also cause sedation. So we're increasing or multiplying that sedative effect. Okay, so be cautious with that. Now, the interaction with warfarin will stems back to THC being a drug that inhibits cytochromes. Okay, remember I talked about that in the last chapter. Cytochromes relate to heme, which then leads us to hemoglobin and blood issues. Okay, oxygenation issues. So this drug absolutely needs to be avoided. Not absolutely, it needs to be avoided, or the dose needs to be adjusted if they're taking warfarin or any other type of blood thinning agents. Okay, so again, doses may need to be adjusted. Okay, now with the calcium channel blockers, remember what they do. They actually decrease blood pressure and relaxes blood vessels. Okay, so therefore we're decreasing that heart rate. You may see some of that. That's where you get the orthostatic hypotension. Okay, so just be mindful of adding to that hypotensive or that low blood pressure and that low heart rate. Excuse me. This medication can also interact with some antiretrovirals. Typically, they'll give this to patients for lack of appetite, okay, in your cancer patients and your patients with HIV. So one other thing is grapefruit juice. Grapefruit juice will increase your adverse effects. Okay, so we don't want to increase anything that they are or they may have. So we don't want to increase those adverse reactions. Sorry, had a child step in. So we don't want to increase those adverse reactions. So now that we've talked about all of those things, let's talk about how we're going to teach them. Okay, so first of all, we know that THC has a propensity to be abused. Okay, so we want to make sure that we educate them about its addictive properties and how to use it appropriately. Okay. Alcohol, of course, is going to do the same thing. It goes back to that sedation, just like your benzodiazepines. If you have a patient taking lorazepam or something of that nature, for insomnia or anxiety, remember those also create sedation in your patients. So as you're doing your drug reconciliations, look for those, okay? And again, going back to that hypotension that we talked about, and that increased risk of falls. We talked about some of the interventions. If we have patients going home, we need to make sure that they are, in fact, aware of, increase your lighting, wear your, rubber-soled shoes or non-skid socks, something like that. Call light when you're in the hospital. Okay, so just know some of those interventions to educate your patient about. Of course, we all know that we shouldn't drive if we're impaired or under the influence of any type of medication, okay? Usually you have the little stickers on the bottle and it will say, do not operate heavy machinery, do not operate a motor vehicle, or something of that nature, okay? So there are several forms of cannabinoids. It could be liquid, it could be capsules. So make sure that if you're measuring, and you probably see this, that you're using the appropriate measuring device provided with that particular medication. So don't be running to your kitchen for a tablespoon or whatever else, okay? Now, if you want to go back and follow along or look at this slide again, look at the table 13.1. So this table is on page 244, and if you will look about the middle of the page, you'll see cannabinoids. Now, it will tell you the first dose should be taken on an empty stomach 30 minutes before meals, okay? After the first dose, then it can be taken with food, okay? Now, we talked about hypersensitivities, so within that 30 minutes, you should see really whether that patient's going to react to that or not, okay? Now, with first doses, of course, it's difficult if your patient lives alone, but if you have a patient going home on this particular medication, you might want to mention to them that they may want to see if they can find someone to remain with them when they're taking their first dose, just to see if they do experience any of those side effects, the dizziness or anything of that nature, dizziness, okay, so that they can report that and they at least have someone with them, if possible, while they're in that particular state, okay? And of course, if they have any type of side effects, again, report that. Okay, so let's talk about your pro-motility drugs. This is going to be your Reglan or your Tigan. These are prokinetics. So we all know that kinetic means movement. So the purpose in them is to increase those contractions in the upper GI tract. Therefore, by increasing contractions, then we increase the speed at which we empty gastric contents. Okay, so pro-motility drugs actually work by blocking dopamine, again in that chemoreceptor trigger zone. Okay, now they work very similar to the phenothiazines, but they do not have the sedating effects like the phenothiazines do. Okay, so pro-motility drugs are typically used for postoperative nausea, okay, vomiting, chemotherapy-induced nausea and vomiting. This one is used for GERD or gastroesophageal reflux disease. And this is where you also see that gastric or gastroparesis that we talked about previously, okay? So just remember that this one also is blocking dopamine receptors. So therefore, we want to use caution when we're assessing our patient about history of Parkinson's, okay? So anything that blocks dopamine, we want to assess for. Any type of antipsychotics that they might be taking, okay? Anything for depression, because remember, dopamine affects a lot of things in our body, and mood is one of them. So one of the most important parts about this is, number one, that it doesn't have that sedation effect with our patients. So that's why we like to use it, although it does have some other side effects that are less desirable, but we'll talk about those as we move forward. Now, if you want to look at this, it's on table 13.1, the Reglan is, and I think that is page 244. Yes. So look on page 244 if you want to follow along with this particular medication. So the most common side effects with this one is drowsiness. It doesn't have that sedate effect on your patient, but it may cause some drowsiness, fatigue, and some restlessness, okay? Some visual impairments, urinary incontinence, and insomnia. Sometimes, yes, the medication that we take to treat something has worse side effects than what we're trying to cure or fix. So the adverse effects of Reglan can be pretty severe. Of course, I always want to make sure that we're assessing for a history of depression, and why. Well, that goes back to blocking that dopamine. We're decreasing the amount of dopamine that's available. And remember, dopamine affects our mood. So with this medication, one of the adverse effects is suicidal ideation. Well, we definitely don't want to give them something that's blocking dopamine, especially if they already have a history of depression, and increase their risk of suicide. Okay. Now, as far as cardiac dysrhythmias, this goes back to dopamine. Remember, dopamine is a neurotransmitter, and it is responsible for our cell-to-cell interactions. Okay, so if we don't have enough dopamine available to send those signals from cell to cell, our heart and GI tract and some other things, they're not going to perform in the way that they were meant to. So this is where you start to see your cardiac dysrhythmias, maybe that seizure activity, and then of course that heart failure. If your heart isn't pumping correctly because it's not receiving the appropriate amount of signals, you're going to start to see some heart failure. Now, one of the others, the adverse effects again, relates back to the lack of dopamine, and you're going to see those Parkinson's, the Parkinson syndrome, the extrapyramidal symptoms, okay, or pseudo-Parkinson is sometimes what they're referred to. So that's your shuffling gaits, your tardive dyskinesias, that neuroleptic malignant syndrome, okay, so anytime you hear neuroleptic malignant syndrome, you should know that it's important to assess vital signs, including temperature, because that is one of the leading cues with neuroleptic malignant syndrome is that extremely high fever. Okay, so I talked a little bit about what those pseudo-Parkinsons look like in the previous chapter, so if you don't remember those, please go back and look over them to make sure that you could recognize what those are on a test. Now, pro-motility drugs are contraindicated in patients who actually take phenothiazines. They are also contraindicated in antipsychotics in any patient taking levodopa carbidopa. And again, that just goes back to blocking that dopamine and the availability of that. Okay, so if your patient has a diagnosis of Parkinson's, then they're taking levodopa carbidopa to increase dopamine. So we don't want to give them a pro-motility that's going to decrease that availability. Same thing with our antipsychotics. Okay, it all goes back to dopamine. We do not want to give them anything that's going to block dopamine first if they're taking something to increase it, and if they're taking another drug that has the same action. So don't give them two drugs that blocks dopamine. Okay, so those are your drug interactions, your contraindications. Now, as far as teaching, we talked a little bit about, of course, anytime you have an elderly patient, and if you think about those Parkinson's syndrome, the symptoms, and that shuffling gait, remember you want to make sure, and sometimes if they're living at home alone, it's kind of hard to teach your Parkinson's patients about removing rugs so that slow shuffling gait don't trip them up, because remember, they're not picking up their feet when they're walking. Confusion, dizziness, anything like that can create a greater risk for falls in our elderly patients. Okay, so again, educating them on that. Even family members, educate them on that. Any thoughts of suicide at all whatsoever, we need to have our patient report that immediately, okay? Because that is one of the adverse reactions to this medication. Any sudden increase in fever, muscle spasms, or any movement that is, just you didn't purposefully make that movement, okay? Because that is, again, going back to those adverse reactions and those extrapyramidal symptoms, okay? So know what those are. You're going to see those over and over and over. When we move into the neuro chapter, you're going to see them again. So if you kind of familiarize yourself with them now, you'll understand it really well when we get into the neuro chapter. Some men will not take this particular category because it can cause gynecomastia, and some may experience erectile dysfunction. So it may be a little harder to get your gentleman to take these medications. Um, so just be mindful of, again, like I say, those EPS, you need to make sure you know what those are. I have several of them listed at the bottom, and if you don't remember what those are exactly, go back to the previous slides and look at those. Okay, so gastroesophageal reflux disease, which we typically just call it GERD, and then peptic ulcer disease, or PUD. So typically our stomach is able to handle that extreme acidic environment, okay? Sometimes during stressful situations, we have patients who develop ulcers in the stomach. Sometimes there are disease processes that affect that mucosal lining and cause destruction or ulcers, or um, also certain chemicals. Sometimes if you ingest a chemical, whether intentionally or unintentionally, it can also affect that mucosal lining, causing damage. Okay, so the ulcerations are typically when we refer to them as peptic ulcer disease. Okay, now if you look at the memory jogger on page 248, it's talking about the prostaglandins that we talked about in a previous chapter. Remember how important those are to maintaining blood flow to the stomach and to the tissues, and how NSAIDs can be harmful to the stomach, especially if we're taking them on a prolonged basis. Okay, we're at risk for ulcers because it's inhibiting that COX-1 and that mucosal lining. Now, GERD is basically just when the contents of your stomach, that acidic contents, reflux back into your esophagus. Okay, so when it refluxes back into the esophagus, that's where you get that heartburn feeling. Okay, so remember we talked about previously that the stomach has its own protective mucosal lining, and then the duodenum also has secretions from the liver, the amylase and the lipase, that protects it. So the esophagus really doesn't have any type of protective anything. So it's at high risk for damage, easily being damaged, okay, without that protectant. Now, typically, peptic ulcer disease and GERD are treated with the cytoprotective drugs, okay? So that's your sucralfate, if I can say that correctly, sorry. Remember, those are Band-Aids. So that's going to help heal those ulcers. Now, proton pump inhibitors are typically used also. Remember, the proton pump inhibitors are your omeprazoles. So that's going to help turn off that pump or turn it down so that you have less acid production in the stomach, okay? The histamine receptor antagonist that's sometimes used is your cimetidine. Again, that's that H2 receptor antagonist just decreases the production of acid in the stomach. So there's a couple of options in treating GERD and peptic ulcer disease. Now, peptic ulcer disease can also be caused by a bacteria. So it's called Helicobacter pylori. We just typically call it H. pylori. Okay, so it's a bacteria in the stomach that can cause ulcers. Okay, and so H. pylori is typically, or I guess I should say peptic ulcer disease, when H. pylori is present, is typically treated with one of the ones we just talked about, like the proton pump inhibitors and those types, in addition to an antimicrobial. Okay, so there is a secondary treatment for peptic ulcer disease if H. pylori is the cause. Okay, so you'll need to know that. Okay, so basically the treatment for peptic ulcer disease and GERD are the same. Okay, so adherence to the medications that you would be giving for peptic ulcer disease for that H. pylori, again, Make sure that you are discussing with your patient about the importance of adherence to those particular medications, because those ulcers are not going to heal as long as that H. pylori bacteria is present. Okay, so it's important to complete that series of medications that's prescribed in order to heal those ulcers. So antacids, this is going to be your Pepcid, your Zantac. Some of us take over the counters that are Tums or something of that nature. So all of our antacids are either calcium, magnesium, or aluminum based as far as ingredients. And so we use these antacids for various disorders in the GI tract, particularly peptic ulcer disease and GERD, or some of us may just, heartburn. Okay. So they basically just kind of neutralize the stomach acid to relieve that heartburn and indigestion. Okay. Now we all know that antacids are only a temporary fix. Okay. They do not cure often if there's an underlying issue. Okay. I may eat something today that didn't agree with me, or I ate late at night and went to bed, which you should not really do. And I just have the need for an antacid today. Okay. If I'm taking them on a daily basis, several times a day, there's probably something else causing that heartburn and GI upset. So they need to be mindful and check with a physician or be seen by a physician. So now let's talk about some of the side effects. Okay, so when we talk about diarrhea being one of the side effects, diarrhea is caused by the magnesium-based ones. And if you think about it this way, you'll remember it. If you think about high fiber foods, then relate that to magnesium and the cause of diarrhea, okay, because we've increased that fiber. Generally speaking, if you have a food that's high in fiber, it's also high in magnesium, okay, so that'll kind of help you maybe relate the two. Now, calcium and aluminum cause constipation. Now, aluminum causes constipation because of its structure, okay? It relaxes the smooth muscles of the GI tract, so basically you just have all of that stuff sitting in there and it's not moving through the GI tract as well, so it's bulking up, okay? So you end up with constipation. Now, some of the other expected side effects are going to be loss of appetite, frequent burping, nausea and vomiting, fatigue, weight loss. And so you can relate some of these naturally. If you have a loss of appetite, you're naturally going to probably have some type of weight loss if it's, for any given length of time. Of course, we're going to have weight loss if we're not able to keep things down. If we're vomiting, we're going to have some weight loss. Okay, so just relating some of those expected side effects. Now, as far as our adverse reactions with antacids, those again are specific to which base antacid you're taking. Okay, the aluminum, magnesium, or calcium. So it just depends on which one you take. So hypermagnesemia is when you have, of course, too much magnesium. So if you think about what magnesium does in the body, it controls our muscle and nerve function. Okay, so that's where you start to see that muscle weakness that's listed as that adverse effect. Okay, it also plays a part in blood pressure. Okay, and so that's where you're going to see that low blood pressure, that hold on. Now, as far as adverse reactions of calcium-containing antacids, this can include bone pain, kidney stones, cardiac dysrhythmias. Okay, so we all know that calcium is an important part of our cardiac function, okay, and production of bone mass. So this is where if we have too much calcium and they're continually building up that bone and absorbing that calcium, you may end up with some bone pain in that case, okay. Now, the aluminum-containing acids can cause mood changes, such as confusion, okay, osteoporosis, and hypercalcemia. Again, aluminum causes that smooth muscle relaxation. So when you think about smooth muscle in the GI tract, we also have serotonin that's present in the GI tract. Okay, so anytime that you're messing with serotonin, you're going to see some mood changes. Now, osteoporosis can occur if we're taking something that's aluminum based. It's coating that stomach and preventing the absorption of certain nutrients such as calcium. Okay, calcium we know plays an important part in cardiac system and our bone density. Okay, so that's where the osteoporosis comes in. Again, as far as drug interactions, it depends upon which antacid you're actually taking. Okay, so always be sure to encourage them to either contact their physician, or if you're the nurse and you're in a facility, we have drug books. You can look that up to educate your patient with. Now, if you look on page 251 on table 13.2, it talks about some of the interventions with GERD and peptic ulcer disease. Okay, so be familiar with some of those. Now, with antacids, you absolutely do need to know that you either take your meds an hour before them or 2 hours after taking antacids. Remember, it's inhibiting the absorption of some of those things because we're coating that stomach lining, so we're not absorbing. So in the box on page 251, it tells you to avoid eating within 3 hours of bedtime because that reduces the risk of any of that heartburn and indigestion, that GERD. Okay. Some of the other things there, just be familiar with is GERD and peptic ulcer disease have similar symptoms to stomach cancer. Okay, so this is why it's important that if you are continually using antacids, you need to have, you need to be seen. Okay, they need to see what's going on. There's some underlying condition. So our histamine or H2 receptor antagonists, this is our Pepcid, famotidine, ranitidine, those drugs, and they work by binding to the H2 receptors in the stomach. Okay, so remember, these are antagonists, so they're decreasing in action. So they're decreasing the production of that nighttime gastric acid. Okay, it also works to decrease acid that your body produces when we're eating something or when we're taking part of caffeinated drinks. Okay, so this particular category, the H2 antagonists, are the ones you'll typically see if you are working in an OR or, you know, if you are the patient. They will probably tell you they gave you one of those medications, especially if it's a long surgery, because if you think about surgery procedures, we have to be NPO, which means nothing by mouth, for several hours prior to surgery. And that's because of the risk for aspiration pneumonia. Okay, we don't want those stomach contents moving back up into the lungs. Okay, so you'll see I have risk for pneumonia in this slide, and we'll talk a little bit more about that. So anyway, you don't want that acid and all those stomach contents just sitting in your stomach eating away at their lining while they're under for surgery. You know, some surgery procedures take 6-8 hours or longer. Think about organ transplants. Okay, so those can be very time consuming, and we don't want to cause an issue if we can prevent that. So if you look at this category, you'll notice that all of them are tadines. Okay, so if you just remember the TIDINE, you will remember that it is an actual H2 receptor blocker. No matter what the drug is, if you remember that suffix, then you'll remember. Okay, so expected side effects with H2 receptor blockers or the antagonists are going to be headache, nausea, diarrhea, constipation, mild abdominal pain, and some may experience confusion, anxiety, or depression. Now, I will tell you that most of those lead to CNS effects or GI effects because H2 receptors are present in various systems. They are present in the cardiovascular system. We have H2 receptors in our CNS system. So those H2 receptors when we antagonize them, can affect many different things. So that's where you get those particular expected side effects, okay? Now, the adverse reactions are rare, and you'll see that some have been reported, the blood disorders, the cardiac dysrhythmias, and your book talks about the at risk for pneumonia. Well, you see that I've put on here. So um, the thinking process on that is you have an increased pH of the stomach, which allows organisms to grow. Whereas normally if it was acidic, it wouldn't be allowed to grow. Okay, it's just going to kill that off most of the time. So if you think about your patients who are in surgery, if they're laying flat and they have all of that acidic, bile and all that other stuff in there, and let's just say they do have acid reflux and or maybe they're in Trendelenburg for positioning or whatever, and they were to have some type of reflux, then they're putting themselves at risk for aspiration pneumonia. Okay, so we always want to be careful with that. Sometimes what we're treating can cause other issues that are worse than what we're trying to treat. Now, um, the drug actions of H2 receptor antagonists also affect liver enzymes. Okay, so when you think about this, remember we talked early on about how every single thing that we take in as far as medication has to go through the first pass effect in the liver. And remember when we talked about that, we talked about the availability once it goes through the first pass effect is less than what the original dose was given. Okay, so with warfarin, your beta blockers, your benzodiazepines, calcium channel blockers, alcohol, um, all of those are going to be affected by that um, issue in the liver with their absorption. Okay, so remember, if you're taking any of those, they may need dosage adjustments. Okay, so if you have a patient who starts to see more bleeding, okay, or a prolonged bleeding time, or an increase in blood pressure, or an increase in heart rate, or an prolonged feeling of sedation, or an overall feeling of sedation, they need to contact their physician, okay, because it's probably an issue where their dosage needs to be adjusted because that liver enzyme has been affected, okay. Now, as far as our nursing responsibilities and teaching with peptic ulcer disease, of course, we always want to make sure that we're assessing our patient for unusual bleeding. So you may see a physician if your patient comes into the clinic or even in the hospital, wherever you might work, and they have this diagnosis of peptic ulcer disease. You may see them do a CBC, a complete blood count. Okay, so they're looking at those red blood cells, the white blood cells. So we want to see if they do in fact have some excessive bleeding or is there some type of infection present. Okay, so in order to get the most bang for your buck with your H2 antagonists, your Pepcid, the Zantac, you want to take those with meals and at bedtime. Now, you will read in your book that if you have a patient who is a smoker, your H2 blockers or H2 receptor antagonists are not going to work as well because smoking increases the acid production in the stomach. Okay, so your smokers are probably going to have to either stop smoking or we're going to have to find something else that works for them, or they may just need an increased dose. Okay, so you'll once again see that we always need to educate our patients on, of course, operating heavy machinery. And again, in your book, one of the side effects of this medication is dizziness. So looking for those changes in our mental status, that confusion, anxiety, and depression. Okay, think about those safety interventions that go along with risk for falls. When anytime we have dizziness or any type of change in mental status, okay, look for those interventions to talk about and to implement. Okay, don't just talk about them, actually do them. Okay, and again, those go back to the presence of those H2 receptors in our central nervous system. Okay, so again, the H2 receptors are found throughout the body, not just in our stomachs. Okay, so that's your H2 receptor antagonists. So if you have any questions about them, again, always send me an email and we'll discuss it further. If you have questions that you need clarification on, please send me an email, okay? Because I want to make sure that I understand it a certain way. And if you're not understanding what I'm saying, then I want to make sure that we get on the same page because I want you to be successful. So one last thing with H2 receptor antagonists, the therapeutic uses for this again is your surgeries, your long surgeries like your bypass surgeries, GERD and peptic ulcer disease. Okay, so that's going to be reflux and then those ulcerations. Okay. So our proton pump inhibitors, or PPIs, are going to be your prazoles, your omeprazoles, your pantoprazoles, and your esomeprazoles. Okay, so those are the ones that we're talking about when we talk about proton pump inhibitors. Okay, so with proton pump inhibitors, this basically their entire function is reducing that gastric acid production by turning off that gastric pump. Okay, so if you can remember that, you will be good. So by turning off that pump, we reduce the acid production, okay, which will then allow any ulcerations in that area of the stomach to heal. Now, proton pump inhibitors are typically given in combination with antibiotics to treat those ulcers, or you may have heard of H. pylori, which is typically an infection in the stomach or bacteria. So they're often given in combination so that we can treat the H. pylori, that infection, and then allowing that reduction in gastric acid, so therefore the ulcers begin to heal. Okay, so if you look on page, I don't remember the page number, I'm sorry, page 250 on table 13.2, then you'll see the drugs within that category. Now, with the proton pump inhibitors, you want to make sure you give them with a full glass of water, and you want to make sure that with this one, you know what that time frame is, 30 to 60 minutes before the meal, okay? Because we want to make sure that we have enough time for that to, excuse me, metabolize there. Now, when we talk about proton pump inhibitors, you always want to make sure that you're telling your patients that this is a temporary fix, okay? If you have a prolonged time that you're using these, then you need to see a physician, okay? There may be something else going on in that stomach lining causing, I guess, that gastric upset or those ulcerations, or there's something else going on causing that GI distress. And we talked about the antibiotics, so make sure also that when you're talking to your patient about the combination, typically with antibiotics, we're killing off the good bacteria in the stomach. So you might want to recommend that they take some type of probiotic, okay, in order to counteract that just a little bit as we kill off that bacteria, that H. pylori in the stomach. So some of the common side effects of our proton pump inhibitors are headache, some mild abdominal pain, nausea, vomiting, flatulence, diarrhea, and constipation or constipation. So these medications may also cause some photosensitivity. So again, reminding your patient to either limit sun exposure or wearing sunblock. Now, one of the side effects of PPIs are, of course, in your book it says low vitamin B12, which then leads to anemia. Okay, so most of the time you'll see it listed as just anemia, but it's pernicious anemia either way. So in order for our body to absorb that B12 appropriately, we have to have enough acid in the stomach to break those tablets down. Okay, but what happens is we turn the pump off so we don't have as much acid production, or we're inhibiting the production of intrinsic factor, which has to be present in the stomach in order to absorb B12. Okay, if you don't get anything else out of this slide, you need to remember that in order to absorb B12 correctly, you must have intrinsic factor present in the stomach. Okay, so the importance of absorption of vitamin B12 is that it relates to the production of red blood cells. Okay, so if we have low B12, then we're not getting enough red blood cells circulating, and we have a whole nother issue to deal with. So remember how important B12 is to red blood cell production. Now, adverse reactions. You're going to see that I have in the slide thrombocytopenia and your hemolytic anemia. Okay, so of course you always want to consider your allergic reactions, pancreatitis, and your book says blood abnormalities. Well, I just told you about B12 and how that can cause a decrease in red blood cells, which then leads to our adverse reactions of thrombocytopenia and our anemias. Okay. So some proton pump inhibitors, specifically, I think omeprazole is the one that has a tendency to affect the pancreas the most. And it just basically affects the secretion of amylase. And so therefore it results in an acute attack of pancreatitis. Okay. Now, drug-to-drug interactions in relation to proton pump inhibitors relate to medications that would decrease cholesterol. So those are going to be your statin medications, your pravastatins, and those types. Remember, statins work, or cholesterol's, you know, it all affects the liver, okay? And so if we have something that is inhibiting that production of amylase and the other productions of things that are going on in the liver, then we're going to see those drugs affected. Okay, so, or those drugs affected by proton pump inhibitors. Now, certain other drugs that you'll see the effectiveness change in is warfarin, alprazolam, and drugs that treat TB. Okay, so knowing that, you have to think about their doses, because either it's going to increase or decrease their effectiveness. So if you have a medication, let's just say warfarin, and your patient is seeing an increase in their bleeding time, so this proton pump inhibitor is increasing the effectiveness of warfarin, they may need a lower dose. Okay, same thing with alprazolam. If your patient is very sedate, then we might want to think about lowering the dose of that alprazolam. Usually it's given for anxiety, so it could have the opposite effect. Maybe your patient is like extremely anxious now, so it can increase or decrease the effectiveness of those drugs. So think about your drug dosages and how we may need to increase or decrease them if we add a proton pump inhibitor to their medication list. So now we've talked about all of that. What are we going to teach our patients? Okay, given all the things we've discussed, first we want to educate them on how to take their proton pump inhibitors. Well, we want to take them 30 to 60 minutes prior to a meal. Okay, so we want to turn off that pump or turn down the secretion of that gastric acid. Okay, so we're slowing the production of that. Now, with proton pump inhibitors, it may take a couple of days for them to actually see a difference and to feel some of that relief, but just educate them on continuing adherence to taking those medications. Now, with proton pump inhibitors, some patients who are at risk for osteoporosis may need to supplement with some calcium. Remember, we talked about having enough gastric acid to break down certain medications or supplements or things like that. So if we can't absorb or break down those medications and absorb them, then we probably aren't going to be able to do so by the very small amounts that we receive in some foods. So we're going to supplement those, okay, with calcium. So therefore, reducing their risk of osteoporosis. Um, Okay, so remember the importance of teaching your patient that if they're if they have to take a proton pump inhibitor for a long time, more than 2 weeks, I think your book says 2 weeks, there may be some type of underlying condition and they need to be seen, okay? A proton pump inhibitor is not a cure, okay? It's not curative for ulcerations. The only thing that proton pump inhibitor is doing is turning down that pump, therefore decreasing the amount of acid produced. Okay, so it can aid in healing by turning down the gastric juices or the acids, but it does not have any curative effects in and of itself. Okay, so teach your patients that if they need to take them longer than 2 weeks, they need to be seen by a physician. Also, one last thing, we did talk about wearing sunscreen and wearing either some protective clothing or decreasing their time in the sun because it can cause some sun sensitivities. Okay, so constipation and diarrhea. Of course, we all know what that is. We've probably all suffered from that, or suffered with it or through that at some point in time in our life. So constipation, again, is just that excessive water is removed by the colon. So we're taking that back into the body. So we end up with that dry, hard stool that's sometimes difficult to pass, okay? Um, Many times you will see this in children especially. They end up constipated because they just ignore the urge to have a bowel movement. They're just too busy playing or, whatever. It can also happen in pregnancy where they've had a child, maybe they've had some trauma to that area, and they want to avoid that. And then, of course, with constipation, we all know that opioids can also cause constipation. Now, sometimes constipation can also be caused just either by a low level of activity or a low fiber diet. Okay, so we're going to talk about ways to teach our patients to avoid constipation. Now, diarrhea, of course, is when you have all of that in the colon and your colon is not absorbing that water, it's letting go of it. So we end up with those runny stools. Okay, it just moves through the colon way too fast. Okay, so let's talk about how to educate our patients on diet and hopefully avoiding both constipation and diarrhea. So when we talk about constipation and diarrhea, acute diarrhea is going to be less than 14 days. Chronic diarrhea is going to be greater than 14 days. Okay, if you've had diarrhea for greater than 14 days, I would hope that you've gone to see a physician before that. But just know the difference between acute and chronic. Okay, now diarrhea can certainly be a result of an imbalance in water reabsorption in the intestines. Maybe there's an issue with the colon, some type of cancer, something is off either in the intestine or maybe in you have some type of infection, or it can also be medication induced sometimes with diarrhea, especially antibiotics. Now, as we talk about this, many times children who suffer from diarrhea, parents immediately want to give them medications to stop that. We don't want to do that if there's an instance in which parasites are involved or some type of infection that we want to get rid of. Any type of organism that is causing the body to have diarrhea, we don't want to give them something to prevent diarrhea, therefore leaving those bacteria or parasites in the body. Okay, we want those to go out. So be mindful of teaching, especially parents, that you don't want to give your children any diarrhea medications, because remember, some of those that they want to give contain aspirin, and we do avoid those in children. We do have to be cautious when using medications for constipation and diarrhea because people can become dependent upon them. Okay, our body gets used to having those laxatives or those stool softeners, and so our colon doesn't work as well. Um, so be mindful of the addictive properties of. I know that sounds really crazy to be addicted to a laxative or an anti-diarrhea, but it does happen. Okay, so just be very cautious, especially with laxatives in your patients, because it can cause that disruption in your electrolytes. Okay, and we'll talk about that. So there are several different types of laxatives. There are of course, stool softeners, osmotic laxatives, saline laxatives, and stimulants, and we'll talk about those as we move through here. If they have some type of GI disease, okay, we have to be careful of that. So we need to know what that GI disease is in order to really decide whether we can give this. Of course, I'm sure your physician has already taken that into consideration, okay, but we have to be mindful of knowing the history. Do they have some type of GI disease or like IBS, or is something else causing it? Okay. Okay, so let's talk about some drugs for constipation. This is going to be your laxatives. Of course, they come in many different forms. So let's talk about what a laxative actually does. I think we all know that the point of giving a laxative is to cause someone to have a bowel movement. Okay, so we're stimulating that peristalsis. Okay, maybe by some of the stimulant laxatives. Okay, or we may just simply be giving a stool softener to soften the stool so that they can have a bowel movement easier and they're less likely to avoid the urge. Okay, so sometimes we use laxatives to either cleanse an area, cleanse a patient prior to some surgeries, um, or if you're going in for maybe a colonoscopy or something like that, where we need to be able to see the entire wall of the bowel, we would use this for that purpose. So let's talk about the bulk forming. So this is going to be your citracel. Okay, it relieves constipation basically by absorbing excess water in the GI tract. Okay, so it's absorbing that fluid to soften up that hard stool. Okay. Um, okay, so bulk forming are actually used um, to prevent constipation. So you can take Citracel on a daily basis, every other day, whatever works for you. Okay. Um, Now, stool softeners we've talked a lot about. This again we use a lot with patients who have um, long-term use of opioids. They have some type of chronic pain or something that they use them for. And so you're going to also see them taking a stool softener, hopefully, um, to allow them to go easier. Okay, it just softens the stool. It doesn't necessarily make them go. It doesn't create that peristalsis. It just makes it easier for them to go. Okay. This is especially important in patients who may have had some type of surgery, especially in the OB world. We use stool softeners with them because they have had probably some sort of trauma to that area. Typically, if they've had an episiotomy or if they are taking, of course, opioids when they go home, we want to make sure that it's easy for them to go. Okay, they're not straining. Um, Now, there are also lubricant laxatives. This is just your glycerin suppositories. Okay, this is given many times in children, neonatal patients, just to create that barrier between the colon wall and the stool so that it can just slide out easier is the only way to really say that. Now, the stool softeners and the lubricant laxatives are both used a lot of times for patients who've had some type of either maybe open heart surgery, or maybe you have a patient who has an aneurysm, or they've had stroke, or any type of abdominal surgeries or rectal surgeries, any type of surgeries where they may have to strain because they're constipated. We want to avoid that. Okay, we don't want them popping stitches or bursting an aneurysm just because they have constipation. Okay, so if we can avoid that, we want to. So when you think about it, especially your patients who have aneurysms or stitches or something of that nature, if you're bearing down to have a bowel movement and you're constipated, you're increasing that pressure, that intracranial pressure. So especially if you were to have an aneurysm in that area, you likely could cause that aneurysm to burst. So we want to avoid that. Osmotic laxatives, again, are just some saline laxatives. This is your lactulose and glycerin. So your osmotic laxatives basically work much like osmosis. It's drawing water into that intestinal tract, that small intestine, that colon, um, to basically soften the stool. It basically causes, I don't want to say it increases, it is basically increasing the bulk of the stool. It doesn't harden it, but it's actually increasing the bulk of it, okay? And by doing so, it's triggering your stomach or your small intestine, GI tract, however you want to relate that, to expel that, okay? So it's going to increase that peristalsis. Now, the osmotic laxatives are the ones that we typically use for bowel prep, okay? Any type of x-ray or GI surgery, okay? This type of laxative works pretty rapidly, typically between about 30 minutes or maybe 6 hours is what your book says, but it is very effective. Now, lactulose can, I guess, can be used in patients who have liver failure, okay, because it does help reduce that ammonia level. So make sure that you take note of that. The lactulose, it can be used in patients with liver failure, okay, it reduces the ammonia level. Your book says by nearly 50%. So that can be extremely helpful in your patients, because a lot of times if you work in a facility and you're like, my patient's had a major change in mental status. Okay, so you start asking questions about what's going on. Sometimes if that ammonia level is really high, you're going to see that patient be extremely confused. Okay, so always think about ammonia levels in relation to confusion, especially in liver failure. Okay. Now, if you have a patient who is in pain from constipation, they have abdominal pain, maybe they're just, I don't know, the type of patient who is like either on bed rest or they're just not getting the activities that they need, poor diets, okay, these are the patients that are typically you are going to see using the stimulant laxatives, and then that's where that addiction or that dependency comes into play, okay? They're not eating appropriately, so they're not getting the fiber they need, and so these are the ones that become physically dependent upon stimulant laxatives, okay? And the more you use them, the more you're going to have to use them, okay? So caution your patients in using those. The stimulant laxatives are pretty instantaneous, okay? They happen pretty quickly because those are usually for immediate relief, but again, your patients do become dependent upon them. This slide is just simply in here as a refresher. Just some of the things I talked about in a previous slide, just so you kind of hit some of the highlights throughout that last slide that we talked about. Okay, so let's talk about some side effects of our laxatives. So first of all, the expected side effects are going to be GI symptoms, your nausea, abdominal cramping, bloating, and some diarrhea. So we've stimulated some peristalsis, so therefore we're creating faster movement, so that's where you may run into some of the issues with diarrhea. Okay, so your adverse effects are going to come from your bulk forming laxatives. They are the safest, however, they're the powdery phacillum type laxatives. So those little dust particles can cause some sensitivities in some patients. Okay, so if they are in fact allergic, then it could cause some anaphylactic issues and therefore some bronchospasms, creating, of course, an emergency situation. Now, patients who have or take those laxatives that are the phacillum type, where you mix them with water, of course, you always want to make sure that, I mean, some people may mix them with, I've seen them with juices and different things, but we always want to make sure that we educate them on mixing them with enough water, at least 8 to 12 ounces, as your book says, so that we reduce that risk of obstruction when they're taking this medication. It begins to gel as we mix it, and so we don't want to try and swallow that and it's not mixed appropriately and then create some type of obstruction. So by mixing this with enough water to take it appropriately, we avoid any issues, hopefully, with the inability to swallow it correctly. And as it begins to gel, we don't create any obstructions. Okay, so no risks of choking or obstruction if we teach them to take it appropriately with the correct amount of water or juice, whatever fluid they so choose. Stool softeners rarely have side effects. However, some lubricant laxatives may decrease the absorption of fat-soluble vitamins. Remember, we're putting a lubricant between the area of absorption and those vitamins that are flowing through the GI tract. Okay, so sometimes it can cause what they consider lipid pneumonia. Okay, a lot of infants, you'll see in your book, they talked about mineral oil. They used to give children years ago mineral oil to help with constipation. So the risk with that would be if you are feeding an infant and you're putting mineral oil in their formula and then you lay them down and a lot of babies burp and have some type of reflux. It gets into their lungs and it can cause that lipid pneumonia. Okay, that mineral oil has been ingested or inhaled into their lungs. Okay, so be mindful of that. So the biggest thing in avoiding that is if you're going to feed them, make sure that they're sitting up for a certain amount of time, 30 minutes or so before laying them down to prevent that. Laxative This is just a slide to cue you in on some of the things I talked about that are extremely important as far as education and your nursing responsibilities. So again, teaching them about that full glass of water, increasing fiber, monitoring blood sugar, and the others that are listed, those electrolyte imbalances that may cause dehydration and that hypokalemia, therefore creating those cardiac effects. So just another slide to reinforce those important parts of um, our responsibilities in teaching our patients about laxatives. Diarrhea can be acute or it can be in relation to some type of illness that someone may have. Again, you may have some type of infection or you may have some type of chronic disease. Okay, so it's acute, can be acute or can be caused by a chronic disease. Okay, so let's talk about some of the drugs to help with diarrhea. I think in the next slide, you'll see a picture of the sympathetic and the parasympathetic systems. Okay, so on this one, you'll see I have cholinergics and how do they perform. So if you look in the parasympathetic system, you'll see a CH in there. That's your acetylcholine. Okay, that's your cholinergic. And then you'll see what cholinergics typically do. Okay, so the cholinergics typically stimulate peristalsis and secretion. So if we use an anticholinergic, then we're going to slow that down and hopefully stop that diarrhea. So again, if you have any questions, look at that next slide with the two systems, and then maybe you'll have a better understanding as to the relationship in cholinergics and anticholinergics and how they work. If not, and you still have questions, I'm always available. So this is the visual that I put in of the autonomic nervous system. So you can see what the parasympathetic does versus the sympathetic. Remember, our sympathetic system is our fight or flight. So with the parasympathetic, remember this is your cholinergics. So you'll see at the bottom, it would typically stimulate that peristalsis and secretion. Okay, so if we give an anticholinergic, it's going to block that stimulation of peristalsis. Okay, so sometimes just seeing or having a visual of that system and what it does, and then if you give something to block it, then maybe you'll remember those things when it comes test taking time. Visuals always seem to work for me when I was test taking, but everyone is different. So it's here if you want to review it. So this is another slide in relation to anticholinergics that I have in here. Again, just reiterating that it decreases that parasympathetic firing that stimulates that normal bowel function. So I don't think anyone escapes nursing school without hearing this little phrase related to anticholinergics. So when you give an anticholinergic, the effects are I can't see, I can't pee, I can't spit, I can't beep. So I have some of the drugs listed here for you. So some of the important things that you want to remember in teaching your patients when it comes to anticholinergics are going to be related to can't see, can't pee, can't spit, can't beep. Okay, so let's talk about a couple of the education pieces. Well, one of the first thing that comes to mind is if we can't have a bowel movement, we don't want to have a continuous cycle of constipation and diarrhea, constipation and diarrhea. So we want to teach them about naturally increasing their fiber or decreasing that fiber in order to control those two things. Now, as far as dry mouth, you can ask them or educate them on, chewing gum or maybe some sugar-free candy, just because it stimulates that saliva. Okay, so those are a couple of things that you can do. So going along with the decrease in saliva flow, we do have the decrease in I'm trying to think of the word, sorry. Let me just say it this way. It is essential for your patient to remain hydrated when taking an anticholinergic, because when we take an anticholinergic, we're decreasing that sweating ability. Okay, so if we decrease our ability to sweat and we're, I don't know, out running a marathon or playing tennis, whatever they may do, then we run the risk of a heat stroke. Okay, so it's very important to teach them about remaining hydrated and maybe avoiding some of those excessive activities. Alcohol again is another one. If we're drinking alcohol and we're taking an anticholinergic, then of course we're going to see that increase in dizziness, drowsiness, again, flushing of the skin, because alcohol, of course, dilates everything, and so does an anticholinergic. Okay, so just a couple of things to educate them about. Okay, so antispasmodics. With our antispasmodics, of course, they work by reducing those muscle contractions in the GI system so that we decrease the cramping, the bloating, and the diarrhea. Okay, so now if you guys will look on page 257 in that particular category, you'll see atropine is listed. So atropine is an anticholinergic. So again, there are several teaching points with anticholinergics that we talked about previously that we just need to be mindful of. One is, of course, sweating. We want to encourage them to maybe reduce those activities that might cause them to overheat, okay, and run the risk of heat stroke. And then we also know that anticholinergics decrease saliva. So if you think about if it decreases saliva, we have that lubricant also in our eyes that keeps them from drying out. So if you think about a patient who's wearing contact lenses, you need to teach your patient that it might not be the most appropriate thing to do when taking this particular drug because one, it can dry and be very sticky, and then of course anticholinergics can affect your vision. So just educate them on not wearing contacts, okay, for both reasons. Now, as far as GI motility, we always have to be mindful of never giving any type of antispasmodic or any antidiarrheal medication if in fact there is some type of infection present or a suspicion of any type of infection, okay? C. diff, for example, they have diarrhea. We don't want to give them something to keep them from having diarrhea and then keep all of that infection inside. Okay, so that's just an example. Now, monitoring vital signs, of course, that heart rate. We're thinking about atropine. Okay, so it can affect the heart rate. It can cause some tachycardia. Phenobarbital is sometimes used in seizure patients. So be mindful of the sedation effects that can have. Okay, so you may have some bradycardia. So those are just some of the things to educate your patient on as far as your anticholinergics and your antispasmodics. Now, one of them, that's going to be your bentyl. If you are giving bentyl, as far as IM, you want to make sure, again, that you're putting it into a large muscle, okay? You don't want to give it in, a tiny muscle. Make sure that you're finding those large muscles because it can be, I guess, irritating to the skin and it can cause some pain. So we want to get it deep into those muscles. So think about some of those, your deltoid, your dorsogluteal, even that vastus lateralis is a fairly developed muscle in adults. So think about, of course, giving those into large muscles. Okay, lastly, we have opioid agonists. So this is your Imodium and your Lamodal. Now you'll notice that Lamodal is a combination drug, and so the reason for that is the atropine takes away the effect of the opioid, that mood elevating euphoric feeling or high that they might get with an opioid. So it decreases the abuse potential. Okay, so by using this opioid, it's basically, again, just decreasing the motility of the stomach to avoid diarrhea. So when we talk about opioids, you have to be mindful, again, of taking anything else that may increase the risks of CNS effects, okay, because they're getting some opioid effect, but they're getting that atropine just to decrease that extreme euphoria. Okay, so they have to be mindful about mixing those medications or taking any other opioid in addition to this opioid agonist. So this is one that you're giving it for diarrhea, but it's an opioid. So remember that an opioid agonist could potentially cause constipation because that's what opioids do. That's a side effect. Okay, so teach your patients to just be cautious in using them. Now, drugs with atropine, of course, I told you in the last couple of slides, atropine is in fact an anticholinergic. So go back and look at those education pieces for anticholinergics if you don't remember those. For dry mouth, again, you'll see ice chips, sugar-free candy, gum, just to keep that mouth moist, that mucous membrane, so it doesn't dry out completely. Because with anticholinergic, remember, it's inhibiting that saliva flow. So if you guys have any questions at all on this chapter, please let me know. Okay, write down your questions as you're going through. Email them to me. I'm going to try and set up a time this week that we can do a meeting either through Teams or a Zoom meeting and discuss some of those. Okay, and please don't hesitate.